I'm Matt, one of the RCEM professors, and here is my proposal for the Emergency Medicine Research Paper of the Year. The ARREST study was published in The Lancet in November 2020. The PICO question it posed was, in adults suffering out-of-hospital cardiac arrest presenting with an initial rhythm of VF or pulsus VT, does the implementation of early ECMO or extracorporeal membrane oxygenation facilitated resuscitation compared to standard ACLS resuscitation improve survival to hospital discharge? It is well documented that out-of-hospital cardiac arrest has poor survival rates. The Paramedic 2 trial showed a 30-day survival rate of 2.8% for all calls out-of-hospital cardiac arrest. The only evidence for ECMO specifically in out-of-hospital cardiac arrest is from observational cohort studies, and although they're encouraging, there are no RCTs to date. ARREST was a single-centre, open-label RCT. The primary outcome was survival to hospital discharge. Secondary outcomes included survival with favourable neurological outcome assessed with blinded functional assessment at 3 and 6 months. The team planned to randomise 174 patients to the trial on hospital arrival. The trial utilised a mixed Bayesian and frequentist statistical analysis. A what? Yes, a mixed Bayesian and frequentist statistical analysis. So this part is pretty smart, and this bit analysis is designed to allay fears of potential trial participants that they have a 50% chance of being allocated to a less effective treatment. And it's particularly relevant here when there is some prior evidence surrounding the improved survival rate with ECMO. Initially, 30 patients are randomised in a 1-to-1 ratio. After 30 patients, Bayesian analysis performed, and the next ratio is determined based on the posterior probability. What is that, I hear you ask? Well, the posterior probability is the revised or updated probability of an event occurring after taking into consideration the new information gained from the first 30 patients. So, if the posterior probability that ECMO is better is 0.7, and the posterior probability that ACLS is better, the standard care, is 0.3, after the first 30 patients, the next 30 patients will be randomised in a 70-30 ratio towards ECMO. Therefore, the likelihood of a participant being allocated any particular arm is dependent on the likelihood of that particular arm being better. If at any review the posterior probability is greater than 0.86, the trial is stopped. That's quite neat, eh? The trial was conducted at the University of Minnesota Medical Center in Minneapolis between August 2019 and June 2020. Adults 18 to 75 years old with an initial rhythm of VF or pulsus VT with no ROSC after 3 shocks and with an estimated pre-hospital transport time of less than 30 minutes were included. The intervention group were immediately transferred to the cardiac cath lab, and unless specific termination of resuscitation criteria were met, then peripheral veno-arterial ECMO was initiated and coronary angiogram with revascularization, if indicated, was carried out. The control group received standard ALS by emergency physicians in the ED. Also coronary angiogram if ROSC was achieved. Both groups received local standard critical care treatment. 36 patients were assessed and 30 were randomised, 15 to each arm. Most were middle-aged men. Around a fifth had coronary artery disease, and you can see here that half had their cardiac arrest in public and 4 in 5 were witnessed and had bystander CPR. After 30 patients, the pre-specified boundary for trial cessation of 0.986 was reached and the trial was stopped. Survival to hospital discharge was significantly higher in the ECMO group, with 6 in 14 of this group surviving to hospital discharge compared to 1 in 15 getting ALS standard care. 1 patient withdrew from the ECMO arm, leaving 14. Absolute risk reduction was 36% with ECMO, with a number needed to treat of 2.8. 6-month survival was 43% in the ECMO group versus 0 in the standard care group due to one of the survivors in the standard care group dying before their 3-month assessment. Survivors in the ECMO group had a good functional neurological outcome at 6 months. So what were the strengths of this study? It was a well-designed, randomized, controlled trial with excellent safety reporting and solid analysis. How can we forget the complex but smart randomization plan ensuring participants were randomized based on the likelihood of either arm being better, and the results were similar to other observational cohorts involving ECMO. Weaknesses included this being a single centre study with small numbers of patients. Patients have had high rates of bystander CPR, short scene and transport times, and early first shocks. The team in Minneapolis were also experienced in delivering ECMO, all of which reduces external validity. So to wrap up, what does this all mean? This RCT showed early initiation of ECMO in hospital in refractory VF out-of-hospital cardiac arrest patients resulted in a 43% survival to hospital discharge. I would suggest we cannot ignore the potential of this treatment any longer, and despite the logistical challenges, we need more RCTs in different settings to see whether the benefit this package of care inferred on this patient group, who we currently have little to offer, can be demonstrated in other hospitals and in other countries. Although there are challenges, including enrolling participants without capacity, especially in Scotland, surely it is now time for a UK-based trial and more widespread use of this potentially life-saving therapy. Thank you. Happy to take questions.